Thank you very much. I'm grateful to the organizing committee and especially Dr. Partha Vishar, who sent me a mail saying that, invited me for this keynote lecture. Well, I'm going to talk about diabetic vitrectomies. Although we've just heard about endoscopic vitrectomies, that's for vitrectomy, that's at the one end of the spectrum, the higher end of the spectrum. Well, I'm going to talk about diabetic vitrectomies that all vitreoretinal surgeons are familiar with. Now, when we start doing our fellowships in vitreoretina and start learning surgeries, the first kind of surgery that we sort of learn are retinal detachments. And gradually, as we progress, we sort of master regular retinal detachments. And then we move on to like macular surgeries. First, we think that peeling the ILM would be a very difficult job, but soon we find out that it's not all that difficult. We can do it. But what we really have to learn are the complex surgeries, especially with the detachments when there is complex RDs with PVRs, and then the diabetic vitrectomies. Once we start doing diabetic vitrectomies, we find that it is fun. Actually, it's fun to do diabetic vitrectomies. And there are certain learning curves, but it is quite gratifying, and it also tests the skill of the surgeon. And for PDRs, what I want to say is that most patients do benefit from PDRs. And PDR surgery allows, requires us to understand vitreous hemorrhage and all the membranes and what is going on in the eye in proliferative diabetic retinopathy. One point of note is that in spite of good treatment like anti-VEGF and PRP lasers, many of the patients eventually need surgery. So surgery is, we need to do surgery because PRP is not the end of the treatment, because the process keeps going on in their bodies. This case, like in 2014, we saw a clear case of PDR. He got some lasers, got some anti-VEGF, but in a couple of years, he did develop all the membranes and required surgeries. And therefore, early surgery is recommended always. You must do an early surgery that gives you a lot of benefits. Now, regarding hemorrhages, you can have hemorrhages behind the posterior hyaloid phase, that pre-retinal hemorrhage. And if it doesn't break through, these hemorrhages tend not to get absorbed for a long, long time. And it's pretty easy to remove these hemorrhages. All you need to do is create a PVD and make an opening in the posterior hyaloid, and that gives you access to underneath the PVD, and you can clear out the blood very easily. And if the macula is okay, then the patient really benefits from the surgery and gets back vision. But often there is breakthrough, and then the whole blood comes into the vitreous, and if it stays for a longer time, the whole vitreous becomes very hazy. A B scan will show all the blood in the vitreous, and then the PVD, and also some blood behind. In these cases, as you cannot visualize where the retina is, the surgery can become difficult, and it's a challenge. You really don't know where the retina is. So all you have to do is look at the undulations, try to figure out where the PVD is, and make a tiny opening, and then remove or evacuate the blood from underneath the posterior hyaloid. And gradually, as you do it, you get a reflex of the retina. And once you can see the retina, you're home, because then you know where you are stationed, and you can easily complete the surgery. Well, that's about hemorrhages. But the real thing is the membranes. Diabetic vitrectomy is all about membranes. To do that, I think all of our fellows and all aspiring surgeons should understand what membranes are and the configuration of the membrane, how membranes occur. A new vessel usually is flat and remains on the surface of the retina. Soon, fibroblasts invade, and you get a fibrovascular complex, and this sticks in with the vitreous and grows into the vitreous. When there's a PVD, the part that's in the vitreous gets detached, and the other part anchoring with the retinal blood vessels gets a traction and you develop a traction detachment. This, a young student should sort of understand this mechanism and should be able to visualize in a three-dimensional aspect, like the last photograph, of exactly what's happening in the retina. If this is understood, then you can really go ahead and do the surgery, because you understand the planes and know how to dissect. Because as it progresses, more and more membranes form and more tractions happen, and you have to get the planes and understand where to dissect and where not to dissect. Well, let's look at this case here. The retina is still flat. There are lots of new vessels, and with anti-VEGF, most of the blood vessels have regressed, and it's now fairly easy just to pick it up with our new cutters and all. You can use the cutters as forceps, but you'll find small tags attached from the underneath of the membrane to the retina, and if the tag is along near the fovea, then you have to be very careful. Instead of pulling, you should just separate it and then go ahead and pull the membrane away, and gradually you can pull with the cutter or with the forceps and gradually remove it, and it's not a difficult job. And also you can find a plane like I'm finding now, when there's a gap between the membrane and the retina, and the newer cutters with the tips so close to the end, you can easily dissect it without damaging the retina. The problem arises when there's associated retinal detachment. When there's an associated retinal detachment, it can be a combined, like you see the tear over there, so it's a combined rhegmatogenous and traction detachment. Then pulling the membrane away, you can also tear the retina, because the retina is often very fragile. So you have to be very careful. Like you see, I've just made a tear. So if you think there is a stronger adhesion, you can circumvent it so that you leave the tag there and not tear the retina. Still, in most cases, gradually, with gradual nudging, you can remove the whole membrane and then do a fluid air exchange and settle down the retina. But so this plane, if you can understand the plane, and if you can understand how much space you have underneath the membrane or the posterior hyaloid, that is the essence of vitrectomy in diabetics. So understanding the plane, even if it's a thin posterior hyaloid or a thick membrane, the plane is the one that you have to understand. And you must have a good machine also, nowadays with high cutting rates and the ports so near the tip, that gives us the advantage of doing good vitrectomies. And we can, most of the time, you can peel off the membranes, but you'll find that at times there are places where the membrane is firmly attached to the retina and it just wouldn't come off, and pulling and nudging at those places can damage the retina underneath, like here. So we normally do surgery with one hand, because one hand we have the light pipe, the other the cutter or the forceps, and pulling like that can damage the retina. And these are the cases where a bimanual surgery can be really benefited. So to do a bimanual surgery, you have to have a separate port, 1 or 2 ports, to put in your chandelier light. In this surgery, I'm putting in two chandelier lights to really illuminate the posterior segment. And in one hand, I've got a forceps, in the other, I've got my cutter. So, and I know that this strong membrane has attachments underneath where I would not have been able to access single-handedly. So with the forceps, I'm everting the membrane and gradually severing the connection between the membrane and the retina, and let the retina fall back without damaging it. So that's the beauty of bimanual surgery. But it's not very often that we do it. It's not, most of the time we can do it unimanually. So bimanual is there always, reserved in cases that we want to do it. Therefore, with these surgeries, a case with diabetic membranes, with careful removal, you can really give benefit to the patients. And even if there is membrane along with traction detachments, you can relieve the detachments and give benefit to the patients. Well, the last thing I want to say is 3D viewing surgery. 3D surgery, as you all know, we have just had sessions in the morning So I won't go into the pros and cons of heads-up surgery. But for those of you who have not done 3D surgery, especially 3D vitrectomies, I'd ask you to just go ahead and try, because the view is exceptionally good. That, I just can't get over it. The view with my regular surgery and the 3D view is exceptionally good. The resolution is so high and the depth of focus is much enhanced. So it's an entirely different experience, especially when doing vitrectomies. Over here, we use the RTVO system, that's the Zeiss system, and the photograph, this photo is obviously a two-dimensional photo. Here, everything you'll see on the screen is double because there are two images there, and with the polarized glasses, the two images fuse and you get a 3D vision. And everyone in the OR, or the fellows and the nurses, and everyone can see in 3D. But you see, this picture, this video was taken regularly in a 2D, the regular video. But here you can also appreciate the great depth and the high resolution. If I compare this with my regular photographs, like the ones that I've just shown in the previous slides, you'll notice that this has greater depth. That is the beauty of this 3D thing. So you do get a real great depth, and when you start removing membranes, in these cases, you can really get the planes, and you can do a really safe surgery. That's what I feel. Like in this diabetic case, you'll notice that with the forceps, I just lift the membrane. Even in this video, you'll see the great separation that you can easily see. And in the 3D, it is much, much more enhanced. So the surgery is actually a different experience than our normal microscopic surgery because of the enhanced depth. So friends, that's all I'm going to say. Just be bold. And the timing of our vitrectomies in diabetics is very crucial. We shouldn't wait too long for vitreous hemorrhage to clear. And if there's traction detachment, especially involving the macula, or if there's combined RDs, I think we should just go ahead and not waste time. Thank you very much for a patient hearing. Thank you, Chairman.
Thank you, Dr. Rahman. That was an excellent talk about how to manage the diabetic vitrectomies. So that's one of the most difficult surgeries which any retinal surgeon will face, and one of the most unpredictable surgeries which we face, because when we see a membrane, you think that it's simple, but then when you go inside, when you start doing vitrectomy, then you realize it's something more difficult, and you made it so simple to look at, and then that's really good.